مع حضرتك.
بسم الله الرحمن الرحيم. كل الشكر للأستاذ الدكتور سامح توفيق على دعوته ليا، وليا شرف ان انا اكون مع في وسط البانل العظيم دهوت. ودلوقتي نقدم الاستاذه الدكتوره رشا طريف. اتفضلي يا دكتوره رشا.
شكرا. يبقى احسن لو موجود طبعا. دكتور رشا.
هتكلمنا عن optimizing the final outcome in children with growth hormone deficiency. دكتورة رشا طريف طبعا معروفة وغنية عن التعريف. هي أستاذة في كلية طب جامعة عين شمس، والحقيقة eminent endocrinologist. أنا شخصيا بستمتع بالمحاضرات بتاعتها، شيقة جدا. ويعني اتكلمنا بالذات عن الشورت ستاتشر.
أي ستاتشر.
اتفضلي دكتورة رشا.
اتفضل عشان خاطري.
بسم الله الرحمن الرحيم. بشكر حضرتك على التقديم الجميل، ويشرفني جدا وجودي مع حضراتكم. بشكر اخويا وصديقي العزيز جدا الدكتور سامح توفيق على دعوتي. مبسوطه ان انا مع حضراتكم النهارده ومع الدكتور سامح بشاركوا النجاح الجميل ده. وبسم الله ما شاء الله القاعه مليانه من مصر كلها بالرغم من السيركمستانسز اللي احنا فيها، وده يبين معزه الدكتور سامح عند الناس كلها طبعا. والحقيقه الدكتور سامح انا اشتغلت كلوسلي معاه، يحب يدخل في التفاصيل، يحب يعمل كل حاجه باخراج جميل وشيك، وده واضح الحقيقه من النجاح بتاع امبارح والنهارده كمان ان شاء الله. بشكر شركه نوفو على دعوتي ان انا اقول التوك دي. هتكلم عن optimizing the final outcome in children with growth hormone deficiency. طبعا حالات الجروث هرمون ديفيشنسي ايوه بتاخد جروث هرمون وده متفق عليه، بس ازاي نقدر نجيب احسن نتيجه ممكنه في الاطفال دول، وهو ده اللي انا هحاول تفوكس عليه النهارده. Let me open the scene by this cartoon. As you see here, this is the typical bell curve for growth. For children, you can see that most of the children lying at the middle of the bell curve, with some of them being at the extreme tall and at the extreme short place of the chart. And most of the parents come with their children asking this very typical question, am I short or not? And this is our job as pediatricians and pediatric endocrinologists to solve these issues and categorize the children in this curve. Growth hormone is needed throughout life, no doubt, in all periods of life. And we all know that there is pulsatile secretion of growth hormone, especially at the time of sleep, at midnight until 4 a.m. And this has got a practical importance to apply in growth hormone testing. And the question is it only growth hormone that we need for the growth of our children? The answer is no. In different periods of life, there are different phases of growth affected by different hormones. For example, in the intrauterine life, we need insulin growth factors, and these are not mediated by growth hormone, and we need insulin as well. And that's why infants of diabetic mothers are large babies, because they have hyperinsulinism, and that's why they are born large, because insulin has got a role in this period of life. In infancy, we need proper nutrition and, of course, intact thyroid functions. In childhood, here comes the role of growth hormone and insulin growth factor 1, which is growth hormone mediated in childhood. And then the thyroid hormone and insulin has got the least role in growth at this period of life. And then we go to the adolescence, where we need synergistic effect of sex steroids and growth hormone working together to achieve the growth spurt. So as you see, different hormones affect growth in different periods of life, and each has got a special role in a special period of life. And as you see, the main role of growth hormone is in childhood and adolescence. We all know the growth hormone IGF axis, basically speaking, the hypothalamus secretes growth hormone releasing hormone, which stimulates antipituitary to produce growth hormone. And this is inhibited by somatostatin. And then the growth hormone, which inhibits somatostatin, and then the growth hormone acts on the liver, producing insulin growth factor 1. And there is a negative feedback by the growth hormone on its own secretion and at the level of the hypothalamus. Also, IGF-1 exerts a negative feedback at the level of pituitary and hypothalamus and stimulatory effect on somatostatin to avoid excessive growth hormone secretion. So, logistically speaking, pathophysiology of growth hormone could be either a defect at the level of hypothalamus, antipituitary, or the liver. And if we take a closer look at the molecular mechanism of action of growth hormone, imagine that this is the wall of the liver cell, and this is the liver cell membrane. And this is how the growth hormone receptor looks like. As you see, the growth hormone receptor is formed of 2 parts, and each part has got extracellular, transmembrane, and intracellular part. So what happens is that the growth hormone molecule binds to its receptor. And here, the 2 parts of the receptor come close together. And this is what we call dimerization of the growth hormone receptor. And then it binds to what we call JAK2 with addition of a phosphate group, leading to phosphorylation of the growth hormone receptor JAK2 complex. And then it binds to STAT protein with addition of a phosphate group. And then it enters the nucleus, causing transcription of target proteins, stimulating MAP kinases, ending by the release of IGF-1 into the circulation, exert its growth promoting effect. So as you see, it's a very complicated mechanism, and any defect at any step with genetic mutation could lead to affection of growth hormone IGF axis in any way. Of course, growth hormone simply promotes growth either by its direct effect on the growth plate or through the action of IGF-1. And the question here, is it only growth? Is growth hormone concerned only by growth of our children? The answer is no. Yes, we all know that growth hormone has got the main role in growth of children and adolescents, but it's not only growth. Growth hormone has got a lot of metabolic actions, like being lipolytic, increasing the bone growth and bone mineral density, and increasing the muscle mass, which is again very important to keep intact in adults with growth hormone deficiency. So the effects of growth hormone differ in different age groups. In childhood and puberty, growth, linear growth, which needs higher growth hormone doses. In adulthood, we need it for metabolic purpose, and here you need lower growth hormone doses. And then we have transitional period, which lies between childhood and adulthood. So these are the diagnostic criteria of growth hormone. As you see here, growth hormone deficiency is diagnosed when the height is more than 2.25 standard deviation below the mean age and sex, when the height SD below mid-parental height more than 2, growth velocity less than 25th percentile over 6 to 12 months, delayed bone age more than 2 standard deviation below the mean, and it's more accurate to calculate the bone age standard deviation score if you have low IGF-1 and or IGF binding protein 3, and of course, low growth hormone provocation test by 2 different tests. In neonates, there are some clues that point towards the diagnosis of growth hormone deficiency, like hypoglycemia, prolonged neonatal jaundice, micropenis, and traumatic delivery. Also, history of cranial irradiation could be suggestive, head trauma or CNS infection, consanguinity or affected family member with growth hormone deficiency, and craniofacial midline abnormalities as well. Also, it's very important to exclude the following before jumping to the diagnosis of growth hormone deficiency: hypothyroidism. And this is very important because if the child has got hypothyroidism, you must treat hypothyroidism first before doing a growth hormone provocation test. Otherwise, you're going to have false low growth hormone in the test. Chronic illness is very important. Chronic undernutrition, as presented by Dr. Sameh, genetic syndromes, and infants born small for gestational age. So this list comes before the diagnosis of growth hormone deficiency. And there are some pitfalls in the diagnosis and management of growth hormone deficiency. First of all, avoid basal growth hormone measurement. This is very important. It's of no importance at all. We must do growth hormone stimulation test because, as you've seen, it's a pulsatile secretion. So you cannot rely on basal growth hormone. We need to do 2 growth hormone stimulation tests, except some few exceptions I'm going to tell you. Blunted response in obese. If you have obese, short child, the growth hormone will be lower. Thyroid function tests should be done prior to growth hormone provocation test and make sure the thyroid function is normal. The bone age does not indicate a definite diagnosis. We need to put the data together, the lab, the bone age, the oxology, the clinical data in order to diagnose. MRI celatosicate should be done if more than 1 pituitary hormone defect. And again, don't forget to exclude normal variants, chronic illness, undernutrition, hypothyroidism, and genetic syndromes before jumping to the diagnosis of growth hormone deficiency. And this is the list of the indications when only 1 growth hormone provocation test is sufficient. CNS pathology, if you have a definite CNS pathology, cellular or supracellular mass, history of cranial irradiation, multiple pituitary hormone defects, proven genetic defects in the growth hormone IGF axis, and if there are clear congenital malformations by MRI, like pituitary stalk agenesis, empty cellular, or ectopic postopituitary. In such circumstances, it's sufficient to do only 1 growth hormone provocative test, and this is because you have a definite pathology. Now, let me take you through the history of growth hormone. How did it pass in different stages? In 1956, growth hormone was first isolated from human pituitary. In 1958, it was obtained from cadaveric pituitaries. In 1960, it was clear that growth hormone deficient children could benefit from pituitary growth hormone. In 1985, the FDA received reports of its association with Creutzfeldt-Jakob disease, and this is a serious neurological illness. And at this year, it witnessed a switch from cadaveric growth hormone to recombinant human growth hormone obtained from DNA techniques, and this is the one that we are using right now these days. So this is what happened in the past. And here you can see the list of the current indications for growth hormone therapy, the ones licensed in USA, and the list licensed in Europe. And of course, pediatric and adult growth hormone deficiency is approved by both. Now, let me take you to this case scenario. This is a 6-year-old boy who had proportionate short stature. He had normal birth weight and length. And by the way, those children are born normal because, as you've seen, growth hormone does not have a role in utero. He's far beyond his mid-parental height. His weight is fine. His growth velocity is very poor, 2 centimeters a year. This is the typical doll-like facies. This was described by Dr. Sameh. As you see, he's like a doll. He has excess abdominal fat, and his IQ is normal. And this is the chart of this boy. He was born normal, infancy normal, and then at the age of 3 years, look at the chart. He plateaued his height completely. His celiac screening is negative, thyroid function, cortisol, ACTH, everything is completely normal. And look at his growth hormone provocation tests, very low growth hormone by 2 tests. And the IGF-1 standard deviation score is very low as well. And it's more accurate to calculate the standard deviation score rather than rough estimation of the lab reference range. The bone age is delayed, as you see. So this is the typical isolated growth hormone deficiency. And we all know the types of growth hormone deficiency. Type 1A, which is the most severe, with antibodies against growth hormone, and response to treatment is very poor. There is also type 1B, which is autosomal recessive, with less short stature, no antibodies, and better response. There's also type 2, being autosomal dominant, and type 3, associated with gamma globulinemia. Of course, there's a great advancement in the genetic testing to identify different types. Would be great if we're able to catch the exact type. And this is the proposed dose for growth hormone deficiency. This is published in Hormone Research in Pediatrics in 2016. The prepubertal dose is 0.025 to 0.035 milligram per kg per day, up to 0.05 milligram per kg per day. And of course, we need higher doses at the time of puberty. And it's very important to stress on the fact that it's given daily, subcutaneous injection at bedtime, 7 days per week. And of course, the dose of growth hormone differs in different age groups. For example, in children, it's 0.025 to 0.035 milligram per kg per day. Transitional period, 0.2 to 0.5 milligram per day. And in adults, 0.1 to 0.3 milligram per day. And here it's very important to adjust the dose according to each age group to get the better results. Again, it's very important to supplement other hormone replacement therapies if you have panhypopituitarism. Correct the central hypothyroidism, hypoadrenalism, and central hypogonadism by giving sex steroid to achieve the growth spurt in pubertal period. And the sequence here is to start by correcting the adrenal functions, followed by the thyroid functions, and then you give the growth hormone and you correct the pubertal status. And this sequence is very important as well. Now, let's get back to this boy. What happened? The boy was given growth hormone, 0.025 milligram per kg per day. He responded initially, but not very well. Why? The question is why. And when we increased the dose, the boy did not respond very well. Why? We are used that cases of growth hormone deficiency respond well to small doses of growth hormone. So why didn't that boy respond to growth hormone therapy? We re-evaluated that boy. We did routine labs, thyroid, adrenal functions, celiac screening, everything is normal. And when we took a thorough history from the parents, this is what they said. The boy refuses to take the injection because he couldn't tolerate the pain. It's a daily difficult task for the parents. And there is a number of steps in preparation of the growth hormone. And the net result, growth hormone is given 3 to 4 days per week. Poor compliance. So this is a story of poor compliance. After we exclude other illness that might be associated, it's very important to check the compliance of the patients. And there are some tips for optimizing the final outcome in children on growth hormone therapy. We start growth hormone as early as possible, once the diagnosis is established. Daily subcutaneous injections at bedtime, 7 days a week. Larger doses are needed at puberty. Doses differ according to different indications. Larger doses are needed for Turner, Noonan, SGA, and ISS. And remember, compliance is very important. This is the hidden enemy. Sometimes the patients are not compliant and we are checking. Why isn't the patient responding? Compliance is the key to success, especially in patients with short stature. And there are a lot of factors affecting adherence to growth hormone therapy, as you see. Chronicity of disease, the doctor-patient relationship, duration of therapy, educational level of the parent, the patient's understanding and psychological status, technical factors, the age of the patient, because adolescents are very difficult to deal with, and finally, the self-administration. And this is a study published in Growth Hormone IGF Research in 2016. And what they found is that moderate to poor adherence to growth hormone was identified in around 34% of the patient. And this is a very high percent, more than what we can expect. And it was also clear that moderate to poor adherence had a negative impact on the growth velocity. If the patients are not properly compliant, they will not gain height. And they found moderate to poor adherence was associated with 61% lower height velocity SDS and 63% lower IGF-1. You can see in the first and in the second bar charts that the better the adherence, the higher the height growth velocity, and the higher the IGF SDS. So it's a really important issue to focus on. Again, when investigating the burden of growth hormone therapy in children and family with growth hormone deficiency from the perspective of the patient, the parent, and the healthcare professional, these were the results, and this was published in Future Science 2016. Most of the children aged 8 to 12 said, I suffer the pain of injection, and this was 54%, more than half. Adolescents said, I suffer the daily task. They are tedious in doing it. The parent said, I'm worried about the side effect of the therapy. And for the doctors and healthcare professional, they considered the most difficult issue in managing was the family's daily task. They are committed to do this every day, and this was 34%. Now, let's go back to this child. Now, the compliance of the child was improved. We had a long discussion with the child. We tried to solve the problems of this family, and the boy is doing very well now. So it's really important to focus on the compliance issue in those children. Another different story is this 9-year-old boy who was growing well and then developed secondary growth failure. His height is -2.5 standard deviation. He developed squint, deteriorated vision, headache, projectile vomiting, and a clear deterioration in the school performance. And this was the chart. The boy was normal, and then secondary growth failure developed 5 months ago, as you see in his chart. His thyroid functions revealed low T4, low TSH. This is central hypothyroidism. Low growth hormone by 2 stimulation tests. This is growth hormone deficiency. And low cortisol and ACTH. Here, the bone age was delayed 1 year, not too much, meaning that the boy does not have the situation long time ago. And definitely this is acquired panhypopituitarism, which should be fully respected. MRI was done, a very large cystic craniopharyngioma. And as Dr. Sameh said, it's not very common. It's rare, but it's there. Please look for craniopharyngioma in secondary growth failure. So what happened to this boy? The tumor was resected, hormone replacement therapy was given, and growth hormone was started after 1.5 years of surgery. The boy did not grow well. So what's going on with that boy? Poor growth velocity. He started to develop some metabolic complications as well. So what's going on with that boy? You know all that persistent, untreated growth hormone deficiency reduces the lean body mass with central adiposity, causing insulin resistance, dyslipoproteinemia, low IGF-1, low bone mineral density, decreased nitric oxide production, endothelial dysfunction, causing atherosclerosis, impaired left ventricular performance, increasing the risk of cardiovascular complications in those children, and therefore it decreases the quality of life and psychological well-being. So it's not only height, it's a lot of things that growth hormone could do when affecting the body. Now, the question with that boy, why didn't the boy respond to growth hormone therapy? We repeated the routine labs, thyroid functions, the adrenal, MRI cell Latosica to make sure it didn't further progress. Everything was normal. And by taking history from the parents, this is what they said. The boy could not tolerate the pain. He's not sure the dose is given. Sometimes he's away from home, so he didn't give the dose. He's not satisfied with the device, and the need for continuous refrigeration is another problem with that boy. So the result, he misses 5 doses per month, which is not few. Compliance problem again. So when investigating the reasons for missed growth hormone doses in treating growth disorders, and this was published in Endocrine Practice 2017, the most common reason for missing doses of growth hormone were patients being away from home and forgetfulness as well, because it's a daily commitment. Sometimes they forget. Also, pain may reduce the patient's adherence to growth hormone. And it was reported that less pain during the injection was significantly associated with better adherence. If you look at this bar chart, you can see that the higher the pain, the less the adherence. And when there is more pain, the child is attached to the device. When less pain, the child is attached to the device, and adherence is much better. Also, confidence in having administered the right dose improves the adherence. When the parents and the child are confident that the child was given the dose, the adherence is better, and vice versa. So convenience and satisfaction with the device was significantly associated with better adherence. There's a very important psychological element on the parents and the child being attached to the device, the degree of pain, reflecting on the compliance later on. Another important point is the storage flexibility that resulted in significantly fewer missed injection in refrigeration-only product. When the child does not need to refrigerate the growth hormone all the time, the adherence was better. But when the child or the parents were committed to store it in the refrigerator all the time, the job was more difficult, so they are not compliant. So refrigeration of growth hormone creates a burden for the patients. And the flexibility in this point is another important point affecting compliance. Now, going back to that boy, the boy had better compliance when we solved all his problems, and now he's doing very well and following up nicely. The last case is a 20-day-old newborn who was born full term, cesarean section, neonatal jaundice. His mother is not diabetic. His birth length and weight are normal. The boy developed recurrent generalized tonic-clonic convulsions, micropenis, depressed nasal bridge, and the rest of genitalia was normal. All his labs were normal, apart from indirect hyperbilirubinemia. And the random blood sugar was found to be very low and not responding to usual lines of treatment. So the next step is to withdraw a critical sample. The baby was found to have ketotic hypoglycemia. And if you look at the endocrine profile, it's all very well except for growth hormone deficiency. And MRI celatosica did not show any structural abnormalities. So this is a typical congenital growth hormone deficiency. And here, growth hormone was started. Initially, the baby improved, but later, 6 months, hypoglycemia recurred, and the baby is not doing well. All the labs were repeated and were found normal. And when investigating with the parents, taking a thorough history, this is what the parents reported. The baby keeps screaming following the injection from the pain. It's a daily difficult task for us to do. A number of steps in preparation, and we are paying a lot of money due to dose wastage. And this is another hidden problem which affects the compliance of the parents as well. And the result, the baby misses 1 to 2 doses per week. Again, compliance issue in another way. So potential growth hormone wastage during dose setting or injection strongly influences the choice of growth hormone injection device from the economic perspective. And this is a very important point because growth hormone is an expensive treatment. So growth hormone wastage poses more economic burden on the parents. So the key device features preferred by users for growth hormone device are reliability, easy use, child and user friendly, minimal pain during injection, safety, storage, and the number of steps in preparation. It seems that these are not important, but this is the hidden part. This is very important for compliance of the patient and the parent to reach the target of achieving adequate growth velocity standard deviation score. So what happened with this baby? We changed the type of the growth hormone, solving the problems of compliance, correcting the mistake. Right now, the baby is receiving 7 doses per week, good compliance, no hypoglycemia, growing well, and most important, a good cost-benefit ratio. And here, I'd like to focus on the cost-benefit ratio. It's not a matter that the growth hormone is expensive or not. We need to calculate the cost-benefit ratio for the choice of the proper growth hormone. Here, we need a very high benefit in relation to relatively lower cost given to the benefit. And this avoids the wastage and makes the parents pay less. And finally, the high velocity SDS is directly proportionate to the level of compliance to growth hormone. It's the most important thing to follow and to focus on. And sometimes we, as busy doctors, do not enter into details with the patient. We just give the dose and measure the height. It's very important to make sure that your patient is taking the proper dose daily, 7 days a week. And I'm sure every one of you has got a lot of compliance stories to tell about patients with growth hormone deficiency. My final conclusions are, and this is the beautiful molecule of growth hormone. I'm in love with the growth hormone. The conclusions are, early diagnosis and treatment of growth hormone deficiency improves the final outcome. Poor adherence is a major problem when treating growth disorders. Growth hormone injection device that facilitate convenience, easy use, and improve the adherence to growth hormone therapy, improve the compliance. Increased treatment adherence and compliance is the cornerstone in treatment to optimize the final height in children with growth hormone deficiency. And finally, the wastage of growth hormone influences the choice of the injection device from the economic perspective, which is very important. And I always like to say that there are two sides of every story, a good side and a bad side. Dr. Sameh showed this photo, and I also like to show this photo. This is the bad side of the story. Short stature could be a problem. The ex-French president, Nicolas Sarkozy, stands on a chair when giving a talk, and he asks his pretty tall wife to wear flat heels. He feels he's short in spite of being the president. Yes, short stature could have a heavy psychological burden. The good side of the story, Lionel Messi. Messi was diagnosed as growth hormone deficiency among his team. And because he is talented, he was supported financially by his team to receive growth hormone until epiphyseal closure. And right now, he's one of the top figures, top football players, and he received the Golden Ball 5 times. Yes, stature could affect the life of people. It's not something luxurious. It's a very important thing. And this is what I think. So this is a successful story, the story of Lionel Messi. And what he said is that growth hormone deficiency did not stop me. And growth hormone changed my life. This is a true successful story. And finally, let me introduce the tallest and the shortest men in the world. This is Sultan Kuzen, a Turkish farmer. He's 2.5 meters. And this is Chandra Badur, 74-year-old Nepalese weaver. He's only 53 centimeters, approaching a newborn. And what Kuzen said is that even though he's very short, I'm very tall, both of us has got struggles in our lives. So height is important. It's not nice being too tall or too short. And finally, I'll end up with this slide, which I really believe in. Better growth changes the future. Thank you very much for your attention.
Thank you very much, Professor Dr. Rasha, for your very nice and interesting talk.
Thank you.
And by the way, we'll postpone all the questions to the end of the session. Question from Dr. Sameh or Dr. Rasha. So far, they're very interesting topics, and now we are going to hear Professor Dr. Ghada Anwar, my dear colleague, and one of our eminent endocrinologists. She's going to talk about syndromic short stature. Okay, Professor.
Okay. Bismillah ar-Rahman ar-Rahim. I would like to thank Professor Dr. Sameh Tawfiq